It's my pleasure to introduce Kate Thompson, who is an associate professor of medicine in the Geriatrics and Palliative Medicine Department at the University of Chicago Medical Center. Kate's clinical interests are primary care for older adults, dementia, and frailty. Dr. Thompson is also the project director of the Supporting Healthy Aging Resources and Education, or SHARE network, which was instrumental in developing today's event. She earned her medical degree from the University of Chicago Pritzker School of Medicine and completed her internship, residency, and fellowship at the University of Chicago Medical Center. Please join me in welcoming Dr. Kate Thompson.
Thank you so much, Maureen, and thank you to SSA and SSA staff for allowing us to host this event here. It's really exciting to see so many faces in the crowd here to learn about this very important issue. Just a few other words of thank you before we get started. As Maureen mentioned, I'm the project director for the SHARE network, which is supported through the Department of Health and Human Services, the Health Resources and Services Administration. So I'd really like to thank them for their generous support that enables us to provide you this CEU course today, free of charge. And I'd also like to thank the Area Health Education Center for helping support this, the Illinois Coalition on Substance Use and Aging, the Chicago Recovery Alliance, and James Kowalski for helping us to provide the naloxone and the training today, the Substance Abuse and Mental Health Services Administration, the Illinois Department of Human Services Department of Substance Use Prevention and Recovery, and all of you for joining me, so thank you. Before we get started, a few other quick logistics. So you all have a folder, hopefully. If you don't, you can run and grab one at our registration table. In it, a few things I'd just like to point out. Number one, you all have an agenda for the day. And so your agenda will point out to you when there's breaks. The restrooms, again, are located out to the sides and down the stairs, so you can find them, and we have breaks scheduled through the day. Lunch will be at the end, but we will have food available kind of throughout the break, so if you need a snack, please help yourself. And the day is sort of broken up. Well, we'll have our first three speakers. After each speaker, we'll have time for a couple of brief questions because we really do want to make sure that you all have the opportunity to get your questions answered. And then we'll have time for more questions and discussion amongst our panelists after they've all had a chance to speak. And then we'll wrap up the day with our naloxone training. And you will have a naloxone packet then to take home with you as long as you complete the card that's also located in your folders. Last but not least, also in your folders, as Maureen mentioned, is our evaluation form for the day. Please take a moment to fill it out because we really value hearing your feedback on what was helpful, what wasn't, or if you have suggestions for us for future programming. All right. So I would just like to get started then with a sort of brief overview to sort of frame our conversation for the day. I want to get to the speakers quickly, so I just have a few slides to sort of contextualize this growing problem of opioids and older adults. And my background with this is as a clinician. So I'm a geriatrician. I take care of older adults in my clinical practice who are over the age of 65. And I'm not an expert in substance use disorders, so I'm excited to learn from our panel today as much as you all. But I am seeing more and more issues with opioids and substance use in my clinical practice, as I'm sure many of you are with your patients and clients. And so I think this is a really timely issue for us to be addressing today. I think also the number of people and the robust response and registration we had for this event really is a testament to the fact that this is something that we're all seeing and we're all trying to cope with and deal with. So I hope you'll really be able to get your questions answered and to take home some skills, knowledge, and resources that you can bring back to your own practice settings. So I just want you all to take a moment and think in your minds how the faces of those who have been affected by the opioid epidemic are maybe represented in the media, what you're seeing in print or television or through social media about who's affected. And I was taking a moment to reflect on this myself, and I hear a lot of stories about younger folks who maybe got hooked on pills and then, became addicted to heroin, or, my husband's from Ohio, and there's a lot of stories in the area that he grew up about small towns who sort of get taken over by pill mills and really become centers for opioid use. But I think, something that we don't always see represented as much in the media is the older adults who are affected by the opioid epidemic. But we probably all could share stories about people we know or who we work with who have been affected. For me, it's a variety of different stories. I have some patients who were prescribed opioids and had them diverted by caregivers because they have high street value. I have other patients who have sort of kind of chronic low-level heroin use, but now are very afraid because fentanyl is sort of infiltrating the heroin in Chicago, and they're hearing stories about people overdosing and dying. So there's all kinds of ways that I think the older adult population has been affected by this issue, and hopefully we'll get a chance to delve into that a little bit more today. So why the focus on older adults? Well, this is a slide that all geriatricians must show at any time we speak, because it really justifies the work that we do. But, you can see that we're at this inflection point now between 2010 and 2020 of this rising growth of the older adult population in the United States. In fact, older adults over the age of 85 are the fastest growing segment of the U.S. population right now. So we're really seeing a boom in the older adult population, including the baby boomers hitting 65. And with that, this population is really not immune to the effects of the opioid epidemic any more than any of the rest of us are, particularly here in Chicago. So a quick few stats about opioids in Chicago. In 2017, there were 796 fatal overdoses in the city, so that's more than gun-related homicide or car accidents. There were over 7,000 non-fatal overdoses, which averages out to about 21 per day. And about 90% of those involved illegal opioids in Chicago. Demographically, this is a little hard for you guys to see maybe, but really it's just showing that sort of in the gender balance, overdose deaths in men are rising. They've sort of stabilized for women. They are also rising in non-Hispanic blacks and in non-Hispanic whites, and really disproportionately affecting those populations. And then I'll really draw your attention here to the graph on the bottom, which is showing overdose deaths broken out by age. And as you can see, to the right of the screen are people who are aging, and so the highest numbers are those in the 45 to 54 demographic, but then in the 55 to 64 and even 65 and older demographics, we're seeing a sharp increase in overdose deaths between even just the last few years. So this is a growing issue for all of us in Chicago, but it's particularly hitting hard our aging population. And I think there's probably a lot of reasons for that, which our speakers may get into today, but clearly this is, becoming an even more urgent to emergent issue for all of us who have older adults in our practices. So, older adults have many risk factors for being affected by opioids and by opioid use, including aging physiology. So older adults tend to have more medical problems. They tend to have more medications prescribed to them. They have more opportunities to have prescription opioids provided to them. And they have higher risk for drug-drug interactions or sort of adverse effects of prescription opioids. They also have many environmental and sort of vulnerabilities that put them at risk. So they can be targets for exploitation due to functional or cognitive impairments, or the fact that they're more likely to have opioids prescribed to them. They may have a lack of access to or coverage for mental health care, or barriers to treatment, including difficulty to travel to places where they can get mental health care. And there's a lot of stigma, both on the part of older adults themselves. So I have many older adults in my practice who aren't really willing to engage mental health providers or see it sort of as a weakness to do so. And I also, and I've probably been guilty of this myself many times, that see a lot of providers who don't think about older adults as having substance use issues or don't screen them for substance use issues. And so that kind of stigma or profiling can come from both sides. Just a quick word about workforce issues. So we have a real workforce gap that's really prepared to take care of older adults in the United States. So only about 5% of social workers identify their primary practice area as geriatrics. Less than 1% of pharmacists have geriatric certification, even though older adults certainly make up the bulk of prescribing. And in medicine, so we have about 18,000 medical school grads per year. Only about 75 train in geriatrics, and only about 35 train in geriatric psychiatry. So there's not that many of us that have additional training in caring for older adults. So today, how are we going to address this issue? We're going to look at it from the perspective of public policy, perspective of medical care, including assessing risk and prescribing, counseling, treatment, and harm reduction. And we have a really distinguished panel of presenters who have a variety of experience and sort of come at this issue from a lot of different angles. And so we're going to give each speaker the chance to talk. After each speaker, we'll have time for a couple of questions, and then at the end, we'll bring all of our speakers up and have a panel so that we can hear sort of their interacting kind of thoughts and comments on some questions from you all. Just a word about our question and answer session. I know there's probably a lot of people in the audience that have a lot of personal stories about their own lives or their clients' lives. I would just ask that if you are going to make a comment, that number one, you sort of respect the privacy of your patients and don't share any identifiable information about patients or clients. And that number two, you make sure you have a question. So I think everyone likes to share stories, but just make sure that to try and keep it brief and make sure that you have a question that comes with it so that we can give everyone a chance to kind of hear each other's thoughts. So I'll remind you of that before the panel.